that they're in the right place if they are here for the State of Virginia legislative briefing from the Hypertrophic Cardiomyopathy Association. We will get started in just one moment. And as we get ready to get started today, please excuse my very rough voice. And I hope it holds out for the entire event. And today we are going to be talking about initiatives that can be put forward in the state of Virginia that will help us to identify families at risk for genetic and acquired heart conditions, and how we can work together to ensure that families are kept whole as long as possible, and also talk a little bit about HCM Awareness Day. So we've got some other people populating, and I'm okay with that. And there we go. Okay, and for those of you who are joining us on Facebook, we will not be taking any questions from the Facebook feed today. If you would like to join us for a legislative briefing either today or in the future, please visit 4hcm.org, and you can go to our events calendar and sign up for an event that might be happening in your state or in another state. So with that said, I'm going to begin out of appreciation for everybody's time today. Hello, my name is Lisa Salberg. I'm the founder and CEO of the Hypertrophic Cardiomyopathy Association. We have been working in this space for nearly 30 years. It's our 29th anniversary this year, which always sounds like you're trying to hold on to your 20s before you give up to your 30s, but we're kind of proud of that 30 years. And we're going to talk to you today about a number of issues. We're going to learn a little bit more about the HCMA, who we are, what we do, and we're going to introduce you to our panelists. Today, we have Dr. Christopher Kramer from University of Virginia, who's going to be talking to you about what HCM is and other forms of genetically hereditary heart conditions are, and the prevalence of these disease states within the state of Virginia. And I'm going to talk a little bit more about HCM Awareness Day and the Children's Cardiac Safety Act, which is the legislation that we are seeking to pass in the state. We're going to be hearing from Kitty and Eric, a mother and son living with hypertrophic cardiomyopathy who reside from Virginia. And then we're going to be hearing from Noah on what we need to do to move this legislation forward in Virginia. And we will be taking your questions at the end of this event. So that said, let me just give you a quick understanding of who we are. We're a 501c3 nonprofit organization serving those with HCM and all thick heart muscle disorders. And we hope to be the preeminent organization in this space, raising the voice of those with HCM and thick heart muscle disorders so that we may prevent untimely deaths and advance global understanding. As part of our mission, we speak to the public, we speak to lawmakers, we speak to policymakers, and of course, we work with families and physicians who are in this space, either living with or treating these patients. And if you have any questions after this event, I encourage you to contact us through any of our social media threads or calling the office or visiting our website. So that's who we are. And I am going to hand over controls at this point to Dr. Christopher Kramer. Chris has a wonderful background in imaging, which is pretty much the cornerstone of all things HCM and thick heart muscles. To understand why the heart is doing what it's doing, we start with understanding the anatomy and physiology, and cardiac MRIs played such a large role in that. And Chris has done some amazing work in this capacity. So Dr. Christopher Kramer, I hand over the presentation to you, and thank you for joining us today.
Thanks for having me. Next slide, please. So yeah, let's talk about what hypertrophic cardiomyopathy is. It's a disease that affects the heart muscle and can lead to other serious health conditions. Generally in HCM, the walls of the heart become thicker than they should be. Often it's one wall as opposed to another wall. It can be asymmetric. This excessive thickening can cause the heart to become stiffer and leaves less room for blood to fill the heart. In general, we suspect that about 1 in 250 people have HCM. So in the United States alone, an estimated 1.3 million people have HCM, but most of those go undiagnosed. So apparently only now it's estimated that 150,000 are currently diagnosed, leaving over 1.1 million individuals with HCM undiagnosed. It's associated with a risk of sudden cardiac death Especially it's the highest, most common cause of sudden death in young people, and including young athletes. It can cause heart failure symptoms and or stroke at any age. While HCM is the most common genetic disease, it's certainly not the only genetic heart disease. This is a list of the most common genetic heart diseases and the estimate low and high end of numbers of patients in Virginia with these disorders. So the range for HCM is between 16 and 40,000 individuals with HCM. And you can see that the other common disorders include dilated cardiomyopathy, which is where the walls are thin and the heart doesn't pump properly, and then anomalous coronaries and other forms of congenital heart disease. And the range of overall number of patients with congenital heart disease is between about 90,000 and 260,000 or so. Next slide, please. So what are the signs and symptoms of HCM and other genetic heart disease? Generally, there can be a family history of heart disease. A patient can present without symptoms and with a heart murmur. The symptoms are generic and associated with many different heart diseases. There's not one symptom that points to the diagnosis. You really need imaging and genetics to seal the deal and make the diagnosis. So the symptoms range from shortness of breath, palpitations, chest pain or pressure, fatigue, lightheadedness, brain fog, fainting or near fainting, muscle pains, and many patients are asymptomatic, which points to why there are so many undiagnosed patients with this disorder out there. Complications of HCM and other genetic heart diseases include fast heart rhythms or arrhythmias. As I mentioned, sudden cardiac arrest is the most feared complication. Heart block, which is leading to low heart rate. Infection of the heart muscle and valves, so-called endocarditis. Life-limiting symptoms, heart failure, and the need for transplant or placement of a left ventricular assist device. So HCM is a treatable disease. In fact, we have very new medications for this that are just approved in 2022 that have made a real impact in the therapy, but it needs to be diagnosed in time so that patients can get on appropriate therapy and before the feared complication of sudden cardiac death. So again, why is early diagnosis important? To identify those who are at risk of sudden cardiac death. They have the potential of receiving an implantable cardioverter defibrillator to prevent sudden cardiac death and give the heart a shock back into normal rhythm should that fast heart rhythms be detected. For patients with progressive heart failure symptoms, as I mentioned, we have new medications. For patients who don't tolerate or do not respond well enough to medications, we have the ability to do surgery or another procedure to treat the heart muscle disease, and if all else fails, a heart transplant. Patients also can present very commonly, in fact, it's the most common morbidity in HCM, atrial fibrillation, a common irregular heart rhythm that's associated with forming blood clots in the heart, which in turn leads to stroke, which is another feared complication. Identifying, again, patient with HCM and patient with AFib allows use of anticoagulation, which prevents stroke. And to treat the atrial fibrillation, we can offer ablation procedures. So it's important to understand that this is the most common, again, genetic heart disease. So understanding the family history is very important. This is a typical pedigree chart where we have four different generations of family. You can see in red the affected family members. Now about 40% of HCM is from a particular mutation in one of the genes that code for a protein within the heart muscle. The other 60% or so, what we call polygenic, meaning there are multiple genes involved, not one particular gene. And then risk factors such as high blood pressure and obesity on top of the genetic predisposition leads to the disorder of HCM. So it's usually familial. The ones that have that one sarcomere mutation are autosomal dominant, meaning the children have a 50-50 chance of getting that mutation, having it passed on to them. So likelihood of an affected parent transmitting the abnormal gene to their child is 1 in 2. So it points out the important taking of a family history as well as genetic testing in affected family members, or even screening of family members. With that, I'll end my portion and pass it back to Lisa Selberg.
Thank you, Dr. Kramer. Okay, so why do we want to recognize HCM Awareness Day? Well, I think you've just heard from Dr. Kramer that this is a disease that can impact families. And within the state of Virginia alone, there are thousands of family members affected that may not know that they even have a risk. So we started a few years ago with an initiative to have HCM Awareness Day recognized in every state. And in New Jersey, we've been doing it for a lot longer because I live in New Jersey. But we have extended our list to many, many states, including some great initiatives in the state of Virginia. So we thank everybody in Virginia, but we still need to do a little bit more. So we're going to keep on with our HCM Awareness Day, which is always the last Wednesday of Heart Month. So you've still got time to participate in our events coming up on February 26th. Please sign up on our website. And why we are actually talking to you today is very specifically focused on what we call the Children's Cardiac Safety Act. And in this act, we want to emulate something that was done in one other state so far, and that is New Jersey. And we've been doing it since 2015. We want to include every well child examination to keep the same consistent messaging as we're using for pre-participation screening physicals and student athletes. We know, unfortunately, that children who die under the age of 24, so young people and children who die under the age of 24 from HCM, 80% of them are not athletes and 20% are. So why should we be doing screening on only athletes? We want to open this up so all families have the opportunity. Excuse me. All families have the opportunity to know their family heart health history and ensure that the right follow-up testing is done. So we are seeking legislation that would allow every well child examination to include the 14-point screening for heart disease as we do for student athletes. We would like to improve professional development for healthcare providers with an online training system. We have it available here in the state of New Jersey, and they will get a CME certificate at the end that they will then submit to their insurance providers, payers, so that they know that they are eligible to get reimbursed for these well child examinations. And it improves their understanding of diseases they may not have learned a lot about in med school, because our knowledge of genetic heart diseases have increased exponentially over the past 10 years. We want to make sure that those student athlete screenings are as high quality as they can be, and that they are including all the right forms, and that we only have one form per state. Some states have allowed different municipalities to create their own, and we lose consistency, and they opt to drop questions that are really important to knowing one's family heart health history and identifying children at risk. And with these two elements of making sure we have our children well protected in the PPE as well as the well child exam, these are the core elements of the Healthy Cardiac Monitoring Act that we originally named, but we've changed the name to the Children's Cardiac Safety Act because it is much more specific to what we're doing. There are also elements in the act that encourage good CPR training in schools, AED placement, and emergency preparedness. While we know that legislation is very difficult to unroll, we have a comprehensive package that each state may customize to their own needs, because they may have laws that are already covering some of these other initiatives. So we have it all in one-stop shopping if you want to take a look at it. And why do we think that this is important, and what are the keys to understanding? This is a bipartisan issue. We are 100% sure that no matter what your political affiliation, you have a heart. And no matter what your constituents' political affiliation, they have hearts too. This is a proactive approach as opposed to a reactive approach. We want to get in front of these families while there's still time to take action to ensure that they have all of the tools necessary to take care of their families. It limits more costly diagnostic procedures to those who are flagged in the screening, and also does, on the other side of this, make sure that we have emergency preparedness plans for those who may not have gotten caught in screening. We know that there are much higher costs associated with those who survive cardiac arrest only to have neurologic damage. So we don't want to see that happen. We only want to deal with the problem at hand and get them the appropriate care for their heart. We want to promote pediatric cardiac health overall, all children, not just athletes. The proof of concept has been proven here in the state of New Jersey. It did not add to the complexity of a pediatrician doing the screening. The parent fills out the questionnaire before they go in to see the doctor. The doctor then knows what the targeted conversation should be with that individual family and can make the appropriate referrals for the appropriate follow-up screening. Some may need an EKG, some may need an echo, some may need a cardiac MRI, some may need a genetic counselor. So there's different things that these people may need rather than just going for very expensive testing right off the bat. And we know that we can save lives with this initiative. We can improve the ability of healthcare providers to identify those who need additional screening in advance in a cost-effective manner. So we were working on this project back in 2020. You know, there was a couple other things going on at that point in time as well, which you might remember. But shortly after we started our work, the American Academy of Pediatrics also started theirs. And shortly, right around the same time we started our initiatives, they published sudden death in the young information for the primary care provider. And it was their call to action that we need to be doing a better job at screening our children for heart disease. And we could not agree with them more. So they came up with the idea and the call to action, and we created the elements that became the Children's Cardiac Safety Act. Additionally, and importantly, I'm proud to say that we are partnering with the American Heart Association, as this is an initiative that we both feel strongly about. And we have been in conversation with leadership at AHA who have supported our language as it is scientifically accurate. And each state representative has access to, each state representative of AHA has access to the information as well. And we are happy to be partnering with them on this. So we also created report cards for each state. And I am super proud of Virginia. You guys are doing really well. You've already scored a B on our report card, but I think we're really close to you guys getting to an A. If we can get this legislation passed, it'll give you a couple more points. And we are excited to see the competition state by state who can get to an A first. So congratulations on everything you're doing already in the state of Virginia. We just think we can make things a little bit better with some smart legislation that helps families identify who's at risk. Now we are going to hear from a Virginia family, which is a son and a mother. And we're going to start with the individual who was diagnosed first. Eric, would you please unmute yourself and tell us a little bit about your story and how it impacted your family?
Well, thank you, Lisa. I really appreciate the time today and for all those that are listening in. My story actually started about 20 years ago, unbeknownst to me. I started my career after college as an Air Force officer in 2000. In 2001, I started going to doctors for symptoms such as high blood pressure, much of which was attributed to stress, which led into other things like heart palpitations, dizziness, chest pain, shortness of breath, as well as imaging in 2003 that noted some thickening in my left ventricle, noted then as lower ventricular hypertrophy. Over the years, the symptoms continued on a low level and continued to go to the doctors. I've always been an athletic person, playing baseball for many years when I was younger, weightlifting, biking, and running in my adult years. 2017, 2018, I started to see cardiologists again about the symptoms that continued throughout my life, thinking that it was all related to just being tired, stressed. I run a real estate team that serves the DC area, which can be a stressful and all-consuming job. But in January 2022, I started training for a half Ironman, so a 70.3 run, swim, and bike race. And in that short period of time right after, I started experiencing 2 days of periods of blacking out, extreme fatigue, and shortness of breath. On the third day, I went into an ER, a local ER, had many heart and head workups and scans, and ultimately was released and cleared to continue training. I went on to complete that 70.3 Ironman, as well as a 10K Marine Corps run that year and an Olympic triathlon. At the end of 2022, started to have, I was seeing cardiologists the entire time. Started into a new cardiologist in October of 23, where I had an abnormal ECG. So I went back. In that meantime, I was experiencing days where I could barely function throughout the day, trouble walking upstairs. And so went back in April of 2023 to that same doctor, March 2023 to that same doctor, had an echocardiogram. Again, the lower ventricular hypertrophy or small thickening in my left ventricle was seen, and was told that I'm okay, continue to follow up with my PCP, and okay to continue on with my training. Could have been some stuff related to some depression medication and sleep medication that I was on. I got to the point where I couldn't function in life, so I decided to apply to some educational places, Mayo being the one that selected me within a very short amount of time. In May of 2023, I heard hypertrophic cardiomyopathy for the very first time as a potential. In July of 2023, I was diagnosed with hypertrophic cardiomyopathy. In October of 2023, I underwent the installation of an ICD, an internal defibrillator, to guard against the risk of sudden cardiac arrest. And 3 months ago, because of the severe obstruction that I had in my left ventricle, I underwent a septal myectomy, or full sternotomy, open heart surgery. I'm happy to say that through all of this, I lived. I had an amazing team surrounding me at the end, including Lisa and her team, as well as the amazing doctors at Mayo Clinic that helped me through. Again, I'm one of the lucky ones. This story continues with my mom after I was diagnosed. I have a brother with 7 nephews, and so we all underwent testing. There are countless stories of those that are not as lucky as me. It's why I'm here to ask for your help today. You have the power to identify earlier, and not let it wait for 20 years like it did for me. And at this point, I really, truly appreciate you listening to my story. I'm happy to turn it over to my mom to continue.
Kitty, you're up. Tell us a little bit about how your son's family heart health history went upstream to you.
Thank you so much, Lisa. I'm so glad I found HCMA. That's all I can say. It's helped me tremendously to understand this journey. For me, I had some symptoms post breast cancer. I was having swelling in my ankles, shortness of breath, fatigue, and some palpitations, and never really put it into HCM or even thinking about it, because every time I would go to my doctor, they would just say I was okay. They never really did anything. And so when Eric got diagnosed, we all had to get echoes. I got my echo and was told it was normal. It was pretty upsetting to see that. When Eric looked at it and said, "Mom, your echo looks similar to mine. I think you need to go to a doctor that has specific, like the Center of Excellence." So I ended up going up to Dr. Ayers, who diagnosed me with HCM, and immediately just felt overwhelming guilt and sadness that I had given such a difficult disease to my son, and eternally grateful that he didn't have a heart attack when he did the half Ironman. It was just a lot to digest, a lot to understand, and I'm so glad I found Lisa and HCMA to help me understand the whole thing about this disease, because I was also a neonatal nurse, but I never really studied cardiology. So I immediately got help with my doctor, So I've been seen frequently. I have been diagnosed with heart failure, class 2, and I'm on medications to help me with my shortness of breath. I still have some abnormal heart palpitations, and they are are following me a lot for that. And I'm getting ready to go up for my annual checkup from my Center of Excellence doctor, Dr. Michael Ayers, who is absolutely fabulous. So looking forward to finding out more good news. I hope that I have a milder case. It's unobstructed. So I was there when Eric went through all of his journey, and I'm so grateful for those doctors to have helped him through such a difficult obstruction in his heart. So at this point, I'm just really happy that we're all getting together and trying to pass this through legislation, because it's so important that children get diagnosed early. As you know, as I have those 7 grandsons, I also have my other son who is still competing in half Ironmans. And so I continue to worry as a mom, but just eternally grateful that all of this is out there for us. And I appreciate you letting me talk about this.
Thank you, Kitty. We noticed the backdrop. She is on her way back from being a snowbird for a couple weeks in Florida, heading back to Virginia.
Yes.
So we appreciate you joining us on the phone. And I'm sure Dr. Ayers is smiling because his boss, Dr. Kramer, is here listening to all those wonderful things that you just said about him.
Thank you.
Go UVA. Okay. So next we have Noah, who's going to come and talk to us for a little bit. Noah is the president of Model Solutions, a mission-driven government relations firm focused on sharing best practices, and came to know us through a friend who was lost to HCM. So Noah, we appreciate you being with us today. And why don't you tell us what it is that we can do to take this home as a law in the state of Virginia?
Fantastic. Thanks, Lisa. So yeah, I've had the pleasure of working with state legislators throughout the 50 states to pass model legislation into law over the past 23 years. And it's my pleasure to volunteer my time to HCMA to work to pass this legislation in Virginia. So the Virginia bill was introduced as Senate Bill 1320 by Senator Lamont Beppe. It needed to be harmonized a bit with the existing statutes in Virginia, and really appreciate the wonderful work that the senator and committee did in the Senate Education and Finance Committee to perfect that legislation and pass it out of committee on January 30th by a unanimous vote of 15-0. And then last week, the bill passed out of the Senate by a unanimous vote of 40-0. And it has been referred to the House Health and Human Services Committee. And so our kind of call to action for folks attending today is we'd love to keep that legislation moving. I think there's, obviously bipartisan unanimous support for early detection and awareness to save lives, and especially for children. So after this call, I believe we'll be sending out some information on how to support and contact your representatives to express support should you desire for Senate Bill 1320. But that is the model bill in Virginia. I think you can skip this next slide. We talked about earlier what the bill does, and I'll turn it back over to Lisa.
I had to mute myself so I can have a coughing fit. Sorry. Okay. So I wanted to take everything that you've heard in the past 28 minutes, and I wanted to bring it home with a real story. Did this young lady live in Virginia? No, she lived in Iowa, and her name is Jillian, and she's pictured here at the end. And I want to tell you a little bit about what happened with her family. Her cousin, Noah, I'm sorry, yeah, I think it's Noah. I'm sorry, you're Noah. Wrong name. I think he's Noah as well. Her cousin was diagnosed with HCM back in 2005. So almost 20 years ago. But they didn't know that this really ran in families, and they didn't really communicate it at that point. He had open heart surgery, valve replacement or valve repair shortly after his diagnosis. Then his father went on to have heart surgery 10 years later. Unfortunately, his father passed away during the surgery. His aunt had developed atrial fibrillation. And then he went back and he had genetic testing, and they found the gene in the family. But they didn't really communicate it through the family yet because there's still a little bit of lack of knowledge. Well, Jillian's mom, Amy, right here, takes her daughter Jillian to a doctor for a well child clearance, does not talk about family heart health history, and there's no signs detected in Jillian, and she is cleared. A year later, almost 2 years today, 3 years today, sorry, Jillian had a murmur detected. In March of that same year, she went for an echocardiogram, an MRI, and an EKG, and she was definitively diagnosed with HCM by imaging, but they didn't have the genetics work back yet, so they sent the genetics out. The day her genetic test returned, unfortunately, it was too late for Jillian. She had had a cardiac arrest that day and did not survive. So we lost her at the age of 17. And had we had this knowledge in the family and understood it within the family of its meaning, they would have been able to get to her in time and potentially have given her a defibrillator, which may have saved her life on that April day. So this is a real family. These are real people, and they live with grief from this point forward because they didn't get there in time. By asking questions about knowing your family heart health history, we may be able to save the next Jillian. And we hope that our friends in Virginia will let us move this legislation forward. If you have any questions and you are a state legislator in Virginia and you have any questions, you may use this QR code at any time to set up an appointment with Julie Russo of our team here. And she'll wave to you in a minute when we come back to full screen. And Julie can help you learn all about the legislation, answer any questions. We're happy to connect you with healthcare providers. Should you have any questions, we're happy to talk to anybody who wants to help us move this bill. So I would open it up to questions at this time. And while we're waiting for some questions to populate, I just want to thank our entire team here at HCMA, our board, our staff, our volunteers, and our partners, because without them, none of this would be possible. And lastly, I kind of sound like the hair club for men. I'm not just the president. I'm not just the CEO. I'm not just the founder. I was a family affected by hypertrophic cardiomyopathy, and I've lost multiple family members, including my father, my uncle, and my sister Lori. And I too would have been lost to HCM if not for a heart transplant, which occurred 8 years ago this month. And my donor's name is Brandy. And I remind everybody how important organ donation is when I have an opportunity to speak. So I encourage you all to let your family know what your choices are with regards to organ donation, because I'm only here because a family said yes to their lovely family member, Brandy, who was 32 at the time she became my donor. So we are here to answer your questions. We are here to talk. I'm going to stop screen sharing now and address any questions that you may have. And there's Julie down in the corner, who you can set up an appointment with by using that QR code. I don't see any questions right now in the Q&A. You're welcome to populate them. We have a small crew live with us, but a lot of you will be watching this in repeat. So should you have any questions for anybody here, you're welcome to call us at 973-983-7429 or to email us at support@4hcm.org. Any final comments, Dr. Kramer? Do we think we need to do this in Virginia? How many people can we help?
Yeah, there are lots of people out there that are not diagnosed that need to be diagnosed, and especially children for pre-participation physicals as the issue raised in the bill, because identifying them before they hit the playing fields and potentially have risk of untoward outcomes would be great to know that these children are being identified.
So Dolores is letting us know that the governor enthusiastically signed a proclamation recognizing HCM Awareness Day that will help us getting bipartisan passage of the Senate bill, ? Oh, will that? Noah, what do you think the tone of the Virginia legislature is today? You think we can bring this one home?
I think all support is greatly appreciated. I think that the Senate really sent a message that, unanimously passing the bill, and look forward to the House taking this up and advancing it along the way as well. And just couldn't be more thankful to everyone who's worked on this and the opportunity to make a difference for children and lives in Virginia.
Thank you, Noah. Going back to Dr. Kramer for a moment, when we identify these families who are at risk, I just want to provide a little bit of context here. We talked about implantable defibrillators, not everybody with HCM or all these other diseases are at high risk for sudden death. How important is it to identify who's at risk, to treat them properly? And what's the difference when we don't treat them versus a community cardiac arrest in outcomes?
Yeah, I think you're right. You know, ICD is not the only therapy offered. There's only a percentage of patients with HCM that are at risk, increased risk for sudden cardiac death, and we continually try to improve the ability to predict sudden cardiac death. But there are many other symptoms, as we talked about, that may require medical therapies. There are new medications coming around the pike every year for this disorder. For many years, we didn't have new medications, but in the last 3 to 5 years, we now have several. So there's lots of opportunity to have newer therapies offered to patients who may need them.
Fantastic. Thank you so much. And a reminder that somebody who does have a cardiac arrest out of hospital, every minute that goes by without defibrillation and good CPR, they lose 10% chance of becoming a viable person after that point. So after 10 minutes, we lose the chance of saving that life. And 10 minutes goes really fast. We've gone through 34, 35 minutes during this call alone. So in that time, we need to get people to get to care immediately. So we need a good emergency action plan in place, no matter where you are. So you can learn more about that at 4hcm.org as well. I thank you all for joining us today for this webinar. And if you are a member of the state legislature in Virginia and would like to talk to us, Julie is waiting for your call at 973-983-7429, or you can set an appointment. Kitty, Eric, thank you so much for sharing your story with us today. Noah, thank you for your efforts. And Dr. Kramer, thank you for all you do for patients every day and your entire team, who I will give a shout out to Virginia, is Virginia's, wait, you're the only HCMA recognized center of excellence in the state of Virginia. So props to UVA. All right. Thank you all for joining. Have a great day.
Thank you.
Thanks, Norman.
Bye-bye.
Thanks.
Thank you.